Okay, now we will continue the second part of liver diseases in pregnancy. We will talk now about acute fatty liver of a pregnancy. This is a serious complication and serious liver implication disease in the pregnancy. Its incidence is low, as we mentioned, and this is in this condition we will find that there is increased free fatty acid, which is normal change of pregnancy to ensure that the fetus has adequate source of energy, with a woman having a genetic predisposition as there is a defect in some coenzyme, dehydrogenase enzyme, and this causes impaired in the intake and oxidation of the fatty acids. It will result in the impairment of the fatty acid uptake by the fetus and the mother. And so 20% of the neonate of the mother who had acute fatty liver disease, they will have some genetic mutation with impairment in the fatty acid uptake. There is increase in the fatty acids from the fetus and accumulation, causing microvesicular steatosis. And this usually occurs in the third trimester, as we mentioned, about 30 to 38 weeks, and the mean about 36 weeks of gestation. So it is a disease of third trimester, and it's peculiar to pregnancy. 20% presents postnatally. Usually the woman having non-specific systemic upset to overt liver failure. Either she had mild symptoms from dyspnea, malaise, generalized ill health, nausea, vomiting, to a severe condition as it is progressed to causing liver failure. The typical presentation, the woman will have 1 to 2 weeks history of nausea, vomiting, abdominal pain, and fatigue, followed by hypoglycemia and sometimes coagulopathy. She will have reduced antithrombin 3 activity, and the condition may progress rapidly to liver failure, as we mentioned, with hepatic encephalopathy. 50% will have signs of preeclampsia, and DIC occurs in about 100% of the cases, in contrast to HELLP syndrome, which have DIC about 20%. So it is more severe than HELLP syndrome. The investigation sent is, as we mentioned previously, liver function test. We have severe elevation, about 7 times of the liver enzymes. It differs from the cholestatic jaundice of a pregnancy, where there is mild increase in these liver enzymes. There is mildly elevated bilirubin level with a prolonged prothrombin time. There is risk of bleeding more, hypoglycemia, thrombocytopenia, hypofibrinogenemia, and elevated serum creatinine level. Management for such presentation, the principal management is please call for help because it is a serious condition. You may ask for the senior obstetrician, physician, blood bank informed, and anesthetic, and some specialized nurses system. The supportive care and prompt delivery is the aim. We give glucose 50% to correct hypoglycemia. We should correct the bleeding tendency by blood products. For example, we may give fresh frozen plasma, cryoprecipitate, fresh blood. We should cover with broad spectrum antibiotic because there is risk of infection, as we mentioned, with encephalopathy, and we should provide pulmonary support. There is risk of respiratory and systematic failure. Importantly, the total bilirubin level may continue to rise for up to 10 days after delivery. So delivery will have, after that, we will have slow correction, may continue up to 10 days. So it is still risky after delivery. So the delivery of the fetus is our aim to get rid of the causative factor. The potential complications, we may have renal failure. As we mentioned, there is multi-systemic failure. We may have renal failure, DIC, excessive bleeding, ascites, and infection with pancreatitis and fulminant liver failure, which require liver transplant in some cases. And the woman may have finally death. Now we will talk about viral hepatitis. Viral hepatitis complicates pregnancy in about 0.2%, and the most common viral agent causing hepatitis in pregnancy is hepatitis A infection. Next, hepatitis B, and for lesser incidence is hepatitis C and E. More in prime gravida and in third trimester may result in fulminant liver failure if it occurs. Viral hepatitis in a pregnancy. This table shows to you the mode of transmission of the hepatitis A, B, C, and E, and chronicity of the disease. And as we know, in hepatitis B, there is about 2 to 6% chronicity, and this is the B infection. And in hepatitis C, we may have about 80% chronicity. The fetal transmission in hepatitis B, about 20 to 30%, which is the highest incidence in the infection, and lesser one is 5 to 10% in hepatitis C. Vaccination for hepatitis A and B are available, and they are safe in pregnancy. Viral antigens are the same in diagnosis to non-pregnant lady, and it is the indicators for acuity or chronicity of the disease. So in non-pregnant state, as we mentioned, we can send for hepatitis viral antigens and antibody to know if it is acute or chronic. So it is the same investigation sent in pregnancy. Pregnant women who are hepatitis B antigen positive in the third trimester frequently transmit this infection to the offspring, to her fetus, in about 90% of cases. And in the absence of immunoprophylaxis, whereas those who are negative are lesser infecting their offspring. So if I find the woman, or if I find the hepatitis B E antigen is present positively, I may expect that the fetus is 90% infected. The treatment by immunoglobulin prophylaxis and should be given to pregnant women within 2 weeks of exposure if she had hepatitis A. 2 hepatitis A vaccine causes using inactivated virus are available and can use during pregnancy. As we mentioned, it is safe. All pregnant women should routinely tested for hepatitis B, antigen and antibodies during the early prenatal visit in all pregnancy. And hepatitis B vaccine should be administered to the women with negative immunity. Hepatitis B immunoglobulin can be given to the patient who are parenterally or sexually exposed to blood or secretion from hepatitis B infected individuals. So if she had contact or exposure and we are suspecting that this lady may have the infection, we can give her the immunoglobulins of hepatitis B type, and during pregnancy it is safe. Interferon and ribavirin therapy improve the prognosis of chronic active hepatitis C in particularly, but both drugs are contraindicated in a pregnancy, so we can only give her the immunoglobulin, and also we can test her for the antibodies in order to provide her vaccination. For symptomatic cases of hepatitis B, we should provide and advise for bed rest. We can use intravenous hydration and general supportive measures if the woman has, for example, hypotension or nausea or vomiting or severe dehydration. All hepatotoxic agents should be avoided in order not to increase the burden on the functioning liver. Antepartum fetal assessment for risk of prematurity and stillbirth is also provided, so I should follow by CTG, by Doppler ultrasound. During labor, fetal scalp blood sampling is avoided because I don't want to prick the fetal scalp. I don't want to increase the transmission through blood to the fetus. There is no evidence that cesarean section is better than vaginal delivery to decrease the incidence of infection. So it is the same. So cesarean section is provided if obstetrical indication is there. It is not aimed to do cesarean section to decrease the incidence of infection or transmission in hepatitis B infection. Okay, so passive after delivery, passive immunization by immunoglobulin in the first 24 hours for the newborn is provided, and with it I should start active immunization, and this will effective in preventing the perinatal transmission of hepatitis B virus in about 90% of cases. Neonates infected at birth have about more than 90% chance of being chronic carriers. So I should give passive immunoglobulin and give the vaccine at once the baby is delivered. Breastfeeding is not contraindicated with patients with hepatitis B if the infant has been immunized. Complication prognosis prematurity may be increased in women with viral hepatitis as we mentioned. Okay. Chronic liver diseases and pregnancy, for example, autoimmune hepatitis, chronic active hepatitis, primary biliary cirrhosis or cirrhosis, this usually can occur for lesser incidence as we mentioned. Severe cirrhosis usually associated with infertility. So women with severe cirrhosis is not that much seen with pregnancy because they already have infertility. Liver disease may decompensate and flare up in pregnancy occurs. So in women with cirrhosis is discouraged or not advised to have a pregnancy, because if her liver is compensating in non-pregnant status, once she got a pregnancy, because of the burden and requirement of a pregnancy, may have liver failure and decompensation. If there is portal hypertension and esophageal varices, this woman will have increased risk of bleeding in the second and third trimester because the pregnancy is causing more vasodilatation, pressure of the gravid uterus, causing back pressure on these varices and exaggerate them, so she may bleed easily. And so the woman should screen for varices in the second trimester.